باید بزنم؟
نه زدن الان رکورد.
من چرا نمیتونم بگردم اسلایدمو نمیتونم برگردم.
اوکی. خب همه چیز اوکی شروع کنم؟
به امید خدا.
اوکی. Dear audience, professors, colleagues, and students, welcome to the webinar. First of all, I want to introduce our valued, respected colleague, Dr. Maryam Yazdizadeh. She is a clinical educator, oral medicine and orofacial pain clinic, UCLA School of Dentistry, and also a family center. And she is a staff dentist, orofacial pain and oral medicine clinician, CAUS. Dr. Yazdizadeh, thanks very much for accepting our invitation and joining us to talk about orofacial pain introduction and treatment. We are pleased to listen to you. Let's start. The stage is yours.
Thank you so much. I should say good morning, everybody. Sometimes good afternoon because it's 10:30 p.m. in LA time. I'm honored to be part of this. This is a lecture. We're going to talk about orofacial pain as a general term because we have a wide audience of dentists, dental students, or other majors, orofacial specialists, residents. So I try to talk about basics and general terms. Every items I talk to today about, it's a wide spread things. We can talk hours and hours about every items of them. But we are not going through the details today. I'm going to introduce orofacial pain to you as a general term, as I said. As we all know, the field of dentistry has evolved over the past 30 years. We are now recognizing many non-dental pain complaints as that present in the orofacial region, and these may mimic the traditional complaints such as toothache. That's our field, we work on it. What's orofacial pain? It's a general term covering any pain which is felt in the mouth area, jaws, and it can extend to the face, head, and neck area. So the pain can sensate in a face area, but can be originated in neck, head, or other part of the face and neck area, and it's not related to the tooth pain. So in the other term, any pain or dysfunction result from any shading of the trigeminal cervical complex is related to this field. Now we just refer to what's the trigeminal cervical complex. You can see in this slide there are two different parts. Any pain arise from them or dysfunction from different parts of trigeminal nerves, V1, V2, V3, or cervical nerves of the spinal cord, C2, C3, since they land and have a coverage at the same site in subnucleus caudalis in the brainstem, they can sense in the same area in the face. You can see the dura mater, a vascular headache, nerves go to the trigeminal ganglion and ended up to the nucleus caudalis sensory relay center in the brainstem. Again, TMJ pain can sense over there, signals can travel over there, muscle pains, head and facial pain, neck pain, sinus problems. So you can see all over this problem can interpret as a facial pain. Go through the nerve issue or nerve pattern. In this slide, there is peripheral damage to the tooth, for example, with the nerves. The signal goes to the posterior horn of the posterior part of the spinal cord, and it passes to the front part of the spinal cord and then go to the brain. And at the same time, you know, at the injury, if there's any dysfunction or injury at different part of the nerve or different part of a body, it can be at periphery in a tooth or a gum or along its pathway or at the central, can pass through the same thing. You can see the compression or perinerval invasion of peripheral branches of neuroplastic mass, for example, or activation of varicella zoster virus in the trigeminal ganglion. All of them can travel the same path. Who are the orofacial pain specialists? In this slide, we're trying to say orofacial pain specialists are specialists who have the knowledge of medical and dental approach in the treatments. They're dentists who have been medically trained to treat pain that arises from trigeminal nerve. Orofacial pain specialty, recognized as a specialty of dentistry that encompasses the diagnosis, management, and treatment of the jaw, pain disorders of the jaw, mouth, face, and associated region. By the American Academy of Orofacial Pain, orofacial pain has been recognized as a specialty last March 2020. And this was a great change in this field. So the specialty of orofacial pain is an evidence-based understanding of underlying pathology, etiology, prevention, and treatment of the disorders, as I said, and it helps the patient to have a better care based on AOP, American Association of Oral Pain, for this disorder, for this issue. Before that, we could practice orofacial pain, but it was not recognized as a specialty, and it's a big change in this field. The prevalence of orofacial pain, as you see in this slide by Lipton et al., announced around 22% of the adult population in the state, in the United States. And among this 22%, 12% of them, they were toothpaste, and other pains are TMJ, headache, and facial pains. This orofacial pain costs over $32 billion in the US every year. So it's a lot of money. Based on the reports, women are more frequently affected than men compared to one. And orofacial pain is often associated with a pain in other body regions. As my colleagues know, we can barely have a patient who purely have a pain in one area, oral and neck, face and neck area. They usually have other complaints like arthritis rheumatoid and fibromyalgia, TMJ problem, and other things. So patient usually has a complex pain of other areas as well. So now, before we start, actually, I wanted to introduce some tools we use in this field. They are different than the dentistry, some of them. First of all, history is very important in this field. Sometimes for the new patient, we spend 1 hour, sometimes 1.5 hours on taking history. And I cannot emphasize enough how important is that, taking history. Asking about medical conditions, psychology condition, and social level of a patient, and stress in his or her life, and all over the body's complaint and medical or dental history or medications or so for the other issues. For the diagnostic tools, we usually use medical devices to examine the nerves of a patient. That's a very important part of the patient's exam, neurological exam. We examine nerve 1 to 12, definitely in every single patient, and it takes time. We use otoscope, fundoscopy. to look at the ear, look at the of ophthalmic disc and eyes, and we sometimes need to block the nerve, peripheral nerve. Sphenopalatine ganglion should be blocked sometimes through the nose area. These are the diagnostic tests. Also, sometimes we need X-rays, including preapical, if it's a one area, specific area damage or involved, panoramic view to evaluate all the teeth of the mouth, and cone-beam CT, if the bone is involved, MRI, MRA. These are all X-rays we may need it. And for sleep study and home sleep study devices, which is part of our facial pain training in UCLA, we also need sleep test and medical doctors referral too. Before I go deeper to the category of orofacial pain, I wanted to share you a case which we saw in UCLA. That's a kind of brainstorm or something familiar with all the colleagues they have worked in this field. Even as a general dentist, you may have seen this type of patients. Sometimes patients, they come and they always refer from, most of the time they refer from endodontist for the tooth pain, which is not the origin of the pain. For example, in this case, you can see patient was a 47-year-old female, pain on the upper right bicuspid area. You can see that first bicuspid is broken and has root canal. Pain of the patients report the pain as a sharp jabbing and hot, burning, poker-like pain. And the dentist found a cracked tooth on that first premolar and did root canal procedure on it. But pain didn't stop, and patient came back to the endodontist and asked for the reason why the tooth is there, the pain is still there. So the general dentist recommended referral to the endodontist to do re-treatment of the root canal. But another family dentist requested another tooth root canal, which was first molar. You can see in the picture that there's a big amalgam filling on the first molar. And they have thought, oh, maybe that's involved, nerve is involved. But one of the family dentist requested the root canal, but the patient decided to ask for more professional consult. So patient was referred to UCLA Orofacial Pain department. Patient described two different pains: sharp stabbing pain with dull aching background pain, intermittent bouts of pain throughout the day or at night. She reported that pain triggers by brushing the teeth, talking, putting on lipstick or makeup, touching gum over right lateral incisor, or moving the lip. So as you can see, as a general dentist, you know, these are not triggers for tooth pain. So we are thinking about, oh, maybe that's another thing involved in this situation. So let's sleep on this patient and go through more slide to see what orofacial pain cover. What conditions does the orofacial pain specialist treat? As you see in this slide, myofascial pain is the biggest and ahead of it. It's a widespread range of muscle pains and TMJ problem, TMDs. Orofacial pain talk about neuropathic pain, also TMJ disorders, as I said, neurovascular pain or primary headaches. And in some orofacial pain programs, obstructive sleep apnea are treated with the mandibular advanced device. But some of the programs, they don't have this part, so they don't work on the sleep apnea. And also oromandibular disorder is part of this field. It's all, as I told you, it's very rare for us to see patient comes with just one pain or one disorder. So most of the time, there are comorbids with the pain. For example, patient has muscle pain, migraine, sleep apnea, and bruxism can trigger the muscle pain or start migraine. So it's a kind of puzzle. When we see the patient and we have a long history of everything, but your pain start with, what's the aggravating factors, and what have worked on you, what made it worse, then you can figure it out one by one, the reason and the different pain problems or different conditions patients have. So you can pick up the treatment that works better for this patient. In this field, you can say patient is unique. Every patient is unique, has unique situation to be treated. So you have to discover what treatment match with this specific patient. As I'm going to a little bit describe all these items I mentioned. The orofacial pain specialists work on it. The main one was TMJ. TMJ is a word of disorders. In this slide, you can see a TMJ problem can feel in different part of the face. As you see, it can show up as a forehead, temple pain, and it can cause migraine headache. It can show up as a sinus type headache or facial pain. Sometimes patient with the TMJ problem comes to us and then complain about buzzing or ringing in the ear. And that's why we have to take a look at the ear for sure. And we sometimes, most of the times, we need the ear and nose doctor clearance for other complication to make sure that the TMJ is responsible for this situation. And jaw problems like clicking, popping of the jaw joint when patients have function like talking and opening the mouth. Other sounds in the jaw area, patient may feel them in the ear or in the face, and may complain of muscle pain on the jaw. Patient comes with a neck problem. Most of our patients, more than 90% of the patients, they have neck problems, neck pain. They are reporting and shoulder aches and back aches, and that can trigger the TMJ problem. Or also, patient might sometimes have arm and finger numbness or pain. Sometimes that issue will show up on the throat area. Then patient has the swallowing difficulties, or even teeth pain. The manifestation of the TMJ problem can be just one tooth pain or the whole quadrant teeth involved. Patient has more opening problem, or sometimes patient has problem with close the jaw, and jaw deviation is another problem. Bite change, it's very common in this patient. Patient feels that they cannot find the bite anymore, or they feel the bite has changed recently. And they can be sensitive to into eye area, pain behind the eye, or migraine headache if patient has. It shows up, it's sensitive to sunlight most of the time. So you can say it's a word of the disorders, and all over the face area can be involved. TMJ is something we are more interested in this field. And TMD is called temporomandibular disorders. Temporomandibular disorders can be this derangement disorder or inflammatory disorders and masticatory muscle disorders. So in a general term, easily speaking, TMD is related to disc problem, or either disc problem or muscle problem. For each of them have a different, we have the different treatment to offer. If it's a muscle problem, which is the most common cases involved. We need physical therapy. We have some home physical therapy to offer, and they are very good, and most of our patients, they respond very well to them. Those are easy to do. There's no need for spending money or um, seeking for the specialty or any luxury treatment, and patient can simply do it at home most of the time. And if they follow the instruction, they can get very brilliant result. Um, Pharmacologic therapy is another one. We can offer NSAIDs most of the time. They work to reduce inflammation in the area. Steroids help. I personally go very little cases with the steroids. And muscle relaxants, they're working very good, brilliant in this field. Sometimes tricyclic antidepressant like amitriptyline, nortriptyline, they can be helpful. Most of our patients, we start with physical therapy. We train them how to correct their posture, because most of the time this poor posture sitting on the computer, especially now after COVID, they have to work from home, sitting on the computer for a long time, and the bad posture, head forward position, that causes lots of neck issues, neck problems, and pain can refer to the jaw area and aggravate the muscle pains here and flare out the TMJ problem. So after posture correction and home physical therapy and stretching exercises and muscle relaxant, and the basic treatment doesn't work, the next step will be trigger point injection. For the muscle involved patients, we do lidocaine injection to the muscle, to the involved muscle for a couple of times, and we see the result. And it can be very good result happening. For the joint, for the disc problems, there are some other treatments, intracapsular injections like steroid injection, hyaluronic injection, PRP injection. I will talk more about that, or other options. And joint lavage work very well. Spleen therapy is one of the main treatment of our TMD patients. You can see here arthrocenthesis on the left picture. You can see the injection of normal saline with one syringe. The right side, you can see lavage with 2 needles. We insert this normal saline to the joint area, and after it was washed off, normal saline and the inflammatory soap can exit from the other needle, as you can see in the picture. Some of the practitioners, they prefer to inject corticosteroids after the lavage, which can be helpful, but for sure we have limitation for them. For the steroid injection to the joint, we cannot do it maximum more than twice a year. I already talked about PRP. That was a project we did at UCLA. Actually, PRP, it's platelet-rich plasma injection. We, in a medical field, it has been there since 1990. Medical doctors, they have used PRP for different fields. They have used it for a bone regeneration on the knee area. The skin doctor, they have done it for the skin rejuvenation, and OBGYN obstetrics, in that OBGYN field, they use it for ovaries, reproduction of ovary system. That's a very brilliant things to do. We have tried it at UCLA in few patients. We started when I was resident at UCLA, and I was honored to be part of that project. We picked up 10 patients at that time, and with a severe pain, which all the other treatment didn't work on them, like patient with the TMD issue, bone resorption, crepitus in the joint. We have tried the medication, physical therapy and splint. And for my cases, most of them, they were involved with the other issues that I remember a case, she had rheumatoid arthritis, fibromyalgia, osteoarthritis of the joint, and then generalized osteoarthritis in TMJ and the other joints of the body. So we tried PRP. The procedure is like we did take off the blood of a patient. You can see it in the picture. We concentrate the platelets and we put them on the centrifuge to separate the cytokine and the growth factors from the blood, which are mostly in the platelets. And they can cause healing. So that was a good, the platelet, the rated growth factor and other growth factors, they are in the concentrated platelet. And they can aggravate the healing process. Here you can see the CBCT of the patient before and after procedure. The left side is the condyle view, coronal view of the condyle. This area you can see the resorption, and then after PRP you can see the regeneration of the bone. Here you can compare it, and this view you can see that a resorption here on the condyle, and here at least it's flat. This is concave, and that was great. We could see out of 8 out of 10 patients had 0 to 3 out of 10 in a VAS pain level after PRP, and 2 of them, one of them didn't change, and the other one had resorption changed to the healing process, and you can see the bone reposition on the joint. That's very promising. And we kept continue that. I know that our residents, they are doing more PRP on patients. It's very safe procedure, and you can do it even every week for a couple of weeks in a row, because it's patient's own blood and you don't inject anything with a side effect from outside of the body to the patient. If it's not helpful, it's not harmful as well. So that was for the bone resorption. There is another pain type we take care of it in orofacial pain, which is called neuropathic pain. We have different type of neuropathic pain: peripheral neuropathy, central neuropathy, traumatic neuropathy, anesthesia dolorosa, burning mouth syndrome. Now it's in this category. Post-herpetic neuralgia, trigeminal neuralgia, glossopharyngeal neuralgia, nervous intermediate neuralgia. This neuropathic pain, they can be divided in different books to intermittent, episodic pain, or constant pain. Some of them are episodic. Most of the neuralgia are considered episodic pain. As you see that nowadays we have too many implants in the patient's mouth. So we can consider more traumatic neuropathy happens. Here, that was a 54-year-old male presented to the clinic with a chief complaint of severe pain in the left lower jaw and teeth. He has a history of car accident 5 months ago that led to the bilateral mandibular fracture, which was reduced by plates and screws. 2 months later, the pain began, and consequently, the plate and screws were removed. The oral surgeon, they tried to relieve the pain. They tried to do something. They removed the plate and the screws 3 weeks ago, but the pain became considerably worse. Pain was in the left lower premolar and mental area, and was described as continuous sharp throbbing pain with intensity of 10 out of 10 associated with electrical component, or on a palpitation that lasts for 5 seconds. Numbness in the left lower mental area was also present. Cold stimulation and talking and touching the teeth and gingiva in the above mentioned area participated in the pain. You see, these are not teeth pain. These are not pulp or periodontal involved. So, and you, as you can see, the teeth in the area look fine. They have some simple feeling, but there is no major issue over there. This panoramic picture was taken after removal of screws and plates, but patients still have severe pain. What do we do in neuropathic pain? Treatments are different. It depends on the patient's whole picture and depends on the area of the pain. If the pain is more peripheral and limited to some specific area, 2-3 teeth and gingiva around them, the topical treatment will be the best. There are some neurosensory stents, as you see, acrylic neurosensory stent, we make it. And we ask the patient to put the topical ointment in it every few hours and a couple of times and use it for a couple of days or weeks. And it can be very helpful. I remember I had another case, a 40-year-old female was very frustrated of different type of teeth treatment. She has been through a lot of root canals on the upper premolar area. Pain still was there, and she looked like depressed to me. So, and after all the tests, I came up with a neuropathic pain on the premolar area. It was so localized, so I preferred to do neurosensory stent. With the topical, we had a kind of mixture of some ointment. You can go with everything you wanted to do, but a mixture of clonidine, ketamine, carbamazepine, ketoprofen, that was helpful for us. So I used it for this patient for a couple of weeks. And also I have seen some in her psych history, I have seen some depression. So I decided to add to that topical treatment and some tricyclics medication. It worked, and patient came back with a thank you letter with a beautiful card, and she said, "You saved my life." And most of the doctors, they didn't believe it's a true pain, and they would look at me and they thought I'm crazy. And they didn't want to help me after root canals and doing a couple of dental treatment. They thought I'm crazy about that. And she got totally fine and came back after a couple of weeks with 0 out of 10 pain. And we continue with the stain, which is less side effect with them. With the tricyclic, we can monitor it and taper it down. Or switch it to another medication. As you see here, anti-seizures are another options. Carbamazepine, oxcarb, phenytoin, valproic acid, they are good medications for different type of neuropathic pain, especially in neuralgia. Sphenopalatine ganglion block can be a test and also can be a treatment. For cluster headache, I remember sometimes it worked, sometimes for some type of neuropathy, we couldn't find any origin or any reason for them. That worked very well. Stellar ganglion block was not done in our clinic. We usually send the patient to the general anesthesia department under the anesthesia. They have done it a couple of times. And radiofrequency ablation also is another treatment for resistant cases in neuralgia cases to medication, and it's done by neurologists in the hospital on the surgery. Another treatment which worked very well was acupuncture. Recently, we have a lot of interest in acupuncture and Eastern medicine. When I was resident, I was And it was a study, one of my colleagues worked on acupuncture effect on burning mouth syndrome, which is a neuropathic pain. And I could see patient came back for years after the study. They believed that it worked somehow. I could pull up another article from Dr. Andrea Satdella and her colleagues. At 2013, they had a lecture. They had an article about acupuncture and the burning mouth syndrome, a pilot study. They reported a reduction in the pain of 0.99 points on the VAS after 8 weeks of treatment, after 20 visits. That's great because, again, you cannot mention any side effect with that, any major side effect, and it's simple. So it's a lot of room here to work on this field more in future. After neuropathic pain, I'm going to talk a little bit about primary headache. As I said, every title here, you can talk hours and hours about them. Here in this primary headaches, just migraine, it can be 2-3 hours talking about migraine and new medications and new treatments about that. But now we just mentioned some points, some little things about them. Tension type headache is very common, especially with the TMD patient. You can see it as a comorbid with the TMD. And cluster headache, chronic paroxysmal hemicrania is a severe, debilitating unilateral headache, usually affecting the area of eye. If you remember, I said some of the headaches are behind the eye area. This is that part of headache. Normally consists of multiple severe yet jerk headache attacks affecting only one side. Another headache is a hemicrania continua. It's a persistent unilateral headache that respond very good to indomethacin. So now the diagnosis is a key point. Golden standard for that is the indomethacin. If you get it, the patient is out of pain and it's wonderful. It's usually unremitting, but rare cases of remission has been documented. Hypnic headache and nomular headache are less common, but in this category. Wanted to talk another case. This is an example of how patients should come to you as a picture of a unique thing. This patient is a 35-year-old female, severe throbbing, pulsating, continuous pain behind her left eye, spread to the jaw and the back of the head. Pain accompanied with feeling of tingling and numbness under her face and the left half of her tongue, arm, and leg. Patient become too sensitive to light and noise and had occasionally nausea. These are the symptoms of migraine headache. Can be. Patient ended up to urgent care. They gave her a mineral dose pack, which is a steroid package for a few days. And also patient consulted a neurologist who put her on Andro 10 milligram, which is a preventive medication for migraine headache. It didn't help in this case. Neurologist switched her to Celexa. Another name for Celexa is citalopram. You guys may be more familiar with this term. And Topomax, 25 milligram, which control her headache, but the side effect of severe anxiety batters her. So you can see when you go back to the pain, part of the pain is headache. The other part involved the TMD, the jaw area. And patient has myofascial pain, capsulitis, poor function. And when the whole story show you that when the neurologist tried to treat headache without considering the myofascial pain, the medication he gave the patient can cause a relief for headache, but aggravated anxiety. And also, I mean, the side effect of as you know, the side effect of citalopram is perfunctional habit. Patients shows more clenching, grinding at night with the citalopram SSRIs in general. So they wanted to help with patient, but if you don't see the patient as a whole picture, it's not helping. So the whole myofascial pain and capsulitis plus other factors like sleep and lifestyle and everything should be as a bigger picture treated. 2 months later, she has been awakened by the sound of her teeth squeezed together and severe pain on her right side of the jaw and limited mouth opening. The pain, headache came back, and also facial numbness happened. So you see, one item, one pain, treating, it's not working. So in the management, the muscle pain can spread to the other area. For example, if the masseter muscle in the left picture, if the masseter muscle is involved, the pain can shows up in different part of the face. So you have to consider that, and you have to make sure in your treatment you treat that other spots, the original. And here on the right hand side, in the right picture, you can see another treatment for people who have the greater occipital nerve involved on the back of the head. Sometimes when you inject lidocaine or a little bit of corticosteroid on that nerve area, patient get relief of that pain. So it's very important to make a good diagnosis. As I told you, sleep apnea is part of the orofacial pain treatment and field in some schools, including UCLA. If a patient is diagnosed with a sleep apnea, they usually go to the medical doctor and they get the CPAP, which is the golden standard for treatment of a sleep apnea. CPAP has problems with the noise and big mask on the nose area or mouth area. Some of patients, they travel a lot, they cannot take it everywhere. So if patient is not comfortable, they refer the patient to us for making a mandibular advancement device. What happened in a sleep apnea? As you see in these two pictures, in the left-hand side, you can see the airway should be a specific size. When patient lay down on the right-hand side at the sleep, the whole mandibular and jaw and tongue will collapse the airway, so patient cannot breathe. Sleep apnea means patient stop breathing at night when he or she lay down for a couple of seconds, and it's a very dangerous thing to brain cells and other organs. That's what happened, and that's the mechanism of mandibular advanced device which helped the patient. We try to move the lower jaw forward, so we try to have more space here for patient to breathe at night when she or he is laying down. So the last slide is about the opportunity here. My numbers here are not very outdated, but I still know there are few orofacial pain specialists in the whole United States. I'm pretty sure in the whole world, there are less than the need in orofacial pain specialists, less than what we need to help the patients. As I said before, dentists cannot, general dentists can have limited information about this field. Also medical doctors, they know some part of it and they don't see the whole picture as a big puzzle, you know. So there is a need here for specialists in this field. This is a very unique opportunity for people who are choosing the different type of dentistry specialties. The demand for dentistry is more than orofacial pain. Of course, everybody has 32 teeth and one team, two team doing. So it's clear, but also the money they make is a good money, smarter with the less work. So it can be a kind of business thinking if they choose orofacial pain, which I offered, especially if you are interested in medical field. It's a very good option to take and very good specialty to follow. Thank you all for listening. And it's all yours, Dr. Kopar.
Dr. Yazizadeh, thank you very much for your precious lecture. It was really interesting and informative. Dear audience, if you have any question, please let me know. We have one question. The question is, do we know the reason why women are more likely to suffer from this type of facial pain?
Yeah, it's like as I told you, there are a lot of comorbid with the orofacial pain, like fibromyalgia, rheumatoid arthritis, as these other disorders are more in females. Orofacial pain disorders are more in females. We don't know exactly. There are some guesses over there, maybe hormones. That's a big guess. Estrogen, progesterone. We all know the migraine headache is more peaking in the fertility time of a woman life. Most of the female, when they go through the menopause, they either stop headache, migraine headache, or have it. There are some exceptions, but most of them, they have less headaches. So that can be a reason, hormones.
Okay,
yeah.
Thanks.
Yeah.
And any other question? It seems that we have no other question and us. We learned a lot, and also it was a very informative lecture. I hope that we'll see you very soon in Iran after the COVID pandemic. Thanks a lot.
Inshallah. Thank you so much.
You're welcome.
Bye.
Bye. Goodbye.